Bismillahirrahmanirrahim. The healing by secondary intention or secondary union proceeds when a large area of hemorrhage and necrosis cannot be totally corrected surgically. Various events in this process are discussed in this video. Following are the references for this. The secondary healing, secondary union or healing by second intention is it occurs when a large area of hemorrhage and necrosis they cannot be totally corrected surgically. Myofibroblasts contract the wound and reinforce the healing with extensive deposition of extracellular matrix that lead to scarring. So this analogy of rebuilding a collapsed wall can be used. It is like fixing a small crack in primary healing. A small crack is fixed and with a bit of mortar, with precise minimal effort and leave little mark. In secondary healing, the wall is crumbled. There is debris, that is necrosis. The foundations is uneven, extensive tissue damage, and the repair crew must clear the repair crew is myofibroblast. It must clear the rubble, that is the inflammation and necrosis, rebuild supportive beam, that are the extracellular matrix and the collagen, tuck the wall together with cable, that is the wound contraction, and plaster everything quickly as happened in this scar tissue, that is the large area. So this happens in burn tissue or burn wound. If burns are superficial, repair from within the wall occurs by the stem cells in the follicle and glands and they patch it. But if deep layers are gone, external bricks, that are the grafts, are brought in. They do not replace inner plumbing, the lost appendages, but messenger from new bricks, the cytokines from epidermal graft, guide the better repair. This image is describing the early phase of wound healing, that is around 24 hours of wound healing by secondary intention, where the wound is large, open, and it is surgically not closed. So here you can see the wound gap is large at the surface. This reflects the significant tissue loss or necrosis that is found typically in burn and large ulcers. There is presence of inflammatory cells and also red cell. These dark purple dots are mostly neutrophils and they are the first responder arriving within hours. They work to clean the wound by phagocytosing bacteria and debris, while these red elements, they are the red blood cells, indicating blood clotting and formation of a temporary matrix. The pinkish layer over here, it is the fibrin clot. It acts as a scaffold for migrating cell and prevent further fluid loss. There is presence of dilated capillaries that are leaky and it represents vasodilation and increased permeability due to factor like VEGF, allowing immune cells and plasma protein to infiltrate the wound. Few fibroblasts are also present over here. These elongated cells, uh, purple stained color that are present in the dermis. They're present in this early stage and they will proliferate in coming days to produce the extracellular matrix and collagen. So in this 24 hours, the dominant process is inflammation. The primary cell are neutrophil. The purpose of this phase is to clear out the debris and microbial defense, initiating the groundwork for repair. This image illustrates the 3 to 7 day phase of the wound healing by secondary intention, which is critical proliferation phase where granulation tissue develops. The granulation tissue develops and the wound begin filling in and reepithelialization process also occur. So there is pink granulation tissue filling the wound base and the tissue is rich with newly formed capillaries and proliferating fibroblasts which are essential for the healing. The granulation tissue provides the scaffold for further epithelial migration and tissue regeneration. So these red branch structures are newly formed capillaries formed by angiogenesis stimulated by VEGF and FGF. Their dense and irregular nature make this tissue appear soft and edematous. The purple cells are dispersed in granulation tissue. These are macrophages. Macrophages are dominant now, having replaced neutrophils. They play a role in clearing debris and orchestrate repair by secreting transforming growth factor beta, platelet-derived growth factor, and other cytokines. The proliferating epithelial cells at the base, the proliferating epithelial cells at the wound edge are also present. These cells migrate horizontally beneath the scab, that is the dehydrated portion of this thrombus, and form a new epithelial covering. The basal keratinocytes at the wound edge are active, mitotically expanding the epithelial sheet. So, reduced clot inflammatory layer is present at the top. The fibrin clot is thinning as tissue remodeling progresses and inflammation begins to subside. So the dominant phase in this at this time is proliferation and granulation tissue formation. Primary cells are macrophages, fibroblasts, and endothelial cells. And the key outcome of this phase or this time is formation of granulation tissue, peak neovascularization, active collagen synthesis, ongoing epithelial regeneration. This stage bridges the initial inflammatory response with the structural rebuilding of the tissue, a pivotal moment in secondary intention healing. Now, this third picture, this image represents the week-long phase of wound healing by secondary intention, highlighting the remodeling and maturation phase that occur after granulation tissue has filled the wound. So it is the phase of reepithelialization. The epidermis appear intact and fully regenerated over the wound surface. The epithelial thickness has normalized, indicating successful restoration of the skin barrier. The spindle-shaped cells or fibroblasts are scattered throughout the pink dermal matrix. These cells are shown lying down new extracellular matrix, especially the collagen. The alignment of fibroblast, this alignment of the fibroblast and collagen fiber illustrates wound contraction, a hallmark of secondary intention healing. The collagen fiber that are these dashed line are filling the dermis, and densely aligned collagen fiber indicative of scar tissue formation are present. These fibers provide mechanical strength to the healing wound, replacing the earlier loose granulation tissue. So the vascularity over here is now decreased. So blood vessel, although it is still present, but the vascularity that was characteristic of this second phase, it is now decreased. They are few and more mature, showing regression of excessive angiogenesis from earlier stage. This is consistent with the blanching seen clinically as vascular density declines. So fat tissue at the base is present. It remains, though its appearance may be altered by early injury or fibrosis, but it is consistently present in all three stages. So the dominant process in this picture is collagen remodeling, wound contraction, and scar maturation. Key players over here are myofibroblast, fibroblast, and regression of the endothelial cell. The clinically, the wound shrinks and hardens. Epidermis is restored, but appendages like hair follicle and sweat glands are absent. The resulting scar is firm but less functional than native skin. This stage emphasizes the functional compromise despite structural closure, characteristic of secondary intention healing, especially in large or deep wounds. This image is showing a stepwise illustration of wound healing by secondary intention. So this process occurs when the wounds are large, gaping, and not surgically closed. Over here, in the initial injury phase, a deep gaping wound with extensive loss of both the epidermis and dermis is present. The wound edges are widely separated and no primary closure is present over here. This represents the starting point of secondary intention healing. So there is no closure, 5-day wound. The fibroblast and myofibroblast, they infiltrate the myofibroblast and fibroblast, they infiltrate the wound. Capillaries begin to form in the granulation tissue, and collagen deposition has started. No closure means epithelial cell must migrate over a large surface, a much slower process than in primary healing. The granulation tissue formation occur. It is present in the wound bed. There is marked angiogenesis, red capillaries, and fibroblast activity is ongoing. The wound is partially filled due to epithelial cell inward migration from the edges, and the tissue appears edematous and vascular, that is typical of granulation tissue. After that, the fourth phase is wound resolution. The wound is now closed by a collagen-rich scar. There is complete reepithelialization. No dermal appendage is seen. Hair follicle or glands are not regenerated. The scar is dense and fibrotic and less functional than the normal skin. The collagen scar is visible as brownish bundle indicating long-term remodeling. So it is a slower process than the primary healing, involve extensive granulation tissue, wound contraction and scar formation. This process is seen commonly in burns, ulcers and large traumatic wound. Uh, so final outcome is a structurally repaired site with functional compromise. So earlier we have seen the healing by first intention in which the scar is minimal, but here this secondary healing is characterized by a large wound or large gap. There is large tissue deficit, fibrin clot is larger and exudate is more. The necrotic debris in the wound area is also more. Inflammation is intense due to affected large area and it is more intense. Then there is exudate formation and fibrin formation. Consequently, a large defect with a greater potential for secondary inflammation mediated injury is formed. So a large granulation tissue is formed. A large area of granulation tissue is formed and this required to fill in by greater number of capillaries with multiple greater number of macrophages with activity by fibroblast as well as myofibroblast that is responsible for the wound contraction as is seen in the healing by second intention. Till 2 week, there, there is presence of type 3 collagen that is replaced by type 1 collagen after 2 week. That is more predominant in weeks after injury. So after weeks or a month, there is complete epithelial restoration. The skin appendages are not formed while a large brown area of the scar is visible. That is pale, avascular, composed of spindle-shaped fibroblast, dense collagen, fragments of elastic tissue, and other extracellular matrix component. Thank you for watching this video. If you have any question, please write in the comment box.